Everyone, welcome to the meeting of Northumberland CCG governing body held on Wednesday the 23rd of March 2022. We are being recorded. This is a meeting in public today, so questions have been raised by the public. They've seen the agenda and the papers beforehand. We will make reference to those questions as we go through the meeting in the appropriate places, and those questions will also get responded to individually at a later date after the meeting. Could I ask you not to use the chat function down the side today or ask questions using the chat? If you want to ask a question, please raise your hand. I'm not going to go through introductions everybody one at a time. If you ask a question, introduce yourself, and if you're presenting, introduce yourself, and we'll take it by that way. We've got some visitors coming. The order of the meeting will be slightly different in that we're going to go through to item 4, and then colleagues from Northumbria are going to join us for the Rothbury Community Hospital discussion, which is item 8. So we're going to do that as our first main agenda item, and then we'll go back to the rest of the agenda after that. Apologies for absence. We have apologies from Dr. Chris Waite and Dr. Robin Hudson. And I'm just going to check with Andrea, is that the most up-to-date list of apologies?
It is, that's the most up-to-date.
Thank you very much. We've had no prior declarations of conflict of interest. Does anybody wish to declare any conflicts of interest just now? No? Okay. And we are quorate, and I'll just look to Rachel for a nod on that, please.
Yes, we are.
Perfect. Thank you very much. So item 4, minutes of the previous meeting and matters arising. So this meeting was chaired by Janet in my absence, and I shall go through one by one pages if anybody wishes to comment or make corrections, and if there's any matters arising, raise them at the end. So page 1 and 2, 3, 4, 5, 6, 7, 8, 9, 10. It's a long meeting, obviously. 11 and 12. Okay, I can see no hands. So the action log. Pleased to say the action log looks green. I'll just go down them one by one, just to check that everybody is happy that they've been closed off correctly. So item 1, this was Claire Coyne and Annie Topping, and some information back to Karen Boyer. So Karen, were you happy that that one was completed?
Yeah, that's fine, Graham.
Thank you. And then the second one, the year-to-date performance of cancer patients with subsequent cancer treatment. There's been quite detailed information circulated, which I have been able to see just the last few days. Have people received that, and are they satisfied that they've had sufficient information there? Thank you. There was a follow-on one with Robin as well, which was related to dementia diagnosis figures, and the main action point there for me was that there was more work to be done around following up on that. Are people happy with the response that they saw on that point? Yeah, good, thank you. And then the final one was from Annie relating to the HCAI and an information exchange back to Karen again.
Yes, she gave me an update, thank you.
Perfect, thank you very much. So we can mark all of those as completed. And we are at 9:35 on the dot, and I am now expecting guests to join us. I haven't seen anybody arriving just yet though, Andrea. I think we will do it rather than complicate it and try to start another agenda item. We shall just sit and wait because we're expecting them at 9:35.
Graham, I think we have got members from the trust already in the meeting.
Are they?
I think, yeah.
Yes,
yes,
we are here.
Hi, Paul and Teresa. Are you there as well?
Yeah, so I don't know if you can see the others, but I'm here. So Paul Pay's Community Business Unit Director. We've also got Marion Dixon and Terry Crichton on the call as well.
Perfect. Thank you and welcome. So this is agenda item 8 relating to the Rothbury Community Hospital, and this is a follow-on. We had a discussion at the Clinical Management Board a couple of weeks ago, and now we're bringing the paper forward to governing body for some scrutiny and assurance from governing body. I think Rachel is going to introduce this item, Rachel Mitchison. So I'll hand to you in a second, Rachel, and then we can take it forward.
Thanks very much, Graham. I'm Rachel Mitchison, a Service Director for Transformation and Integrated Care, and you'll see in your packs that there is a sort of summary report, PowerPoint presentation, and then a quality and equality impact assessment. So I think what the best order to go through this is if I hand over to Paul to do the presentation first and take you through this new model of care for Rothbury, and then if it could hand back to me, I'll go through the other papers for you. So thank you, Paul.
Okay, I'm just going to share the presentation. Okay, can I just check, can people see that?
Yeah, we can see that. Yeah. Thanks, Paul.
Okay, so thanks for the opportunity. I think we just wanted to outline, there's obviously been a lot of work over a number of years looking at Rothbury and plans and trying to work through to a new position. And so what we want to do today is share that with you, our current thinking about the developments and hopefully going forward with a proposal that meets the needs of the population and is both exciting and I think also points a way to where we hope to go in the future with a mixed model of how we deliver care in the community backed up by beds. So just to recap, there was obviously a decision in 2016 to temporarily close those inpatient beds, and then that led to a recommendation to permanently close it. A number of things followed from that, and we've also made presentations to the OSC, and there have been lots of discussions over the years with the CCG about new models, and we were working up a new proposal that had come to the CCG previously, including a flexible bed model. And then COVID came and that disrupted those plans. And you know, if we go back to those initial ambitions, it was to try to deliver a community facility that was nurse and therapy led, that had medical cover, and it had a flexible bed base. And so we were looking at delivering a team that could look after people in their own home or in hospital, and people would be wherever was most appropriate to meet their needs, primarily at home, but with the hospital beds to back them up. So we started to do work on both the estates and looking at recruitment of those teams, with an aim to be operational in April 2020, so 2 years ago now. And as I said before, COVID then hit. So we ran into challenges even before COVID, and that was partly around recruitment. We had a lead-in post who's there, who's been part to developing these new plans too. But there were also challenges around the financial modelling around that and governance issues too. So those developments were put on hold. And then probably over the last 6 months to a year, we've really started to motor again on trying to come up with, well, what's the current situation in Rothbury? What have we learned through COVID? What does the new model need to look like? So we've learned a few things from that. We need a bit more flexibility around beds, around staffing. Infection control issues have come to the fore as well. And very much the drive throughout Northumberland has been not about hospital beds, but about delivering healthcare in community settings, but also using beds in different ways, looking at the role of intermediate care and so on. We've done quite a lot around making sure that people who are medically stable, medically optimised or fit shouldn't be in those hospital beds by getting them home or using intermediate care facilities. And we've done quite a lot of audit work looking at over the last period of time how many residents from that Rothbury area have actually been in hospital beds who could be managed more locally if there were beds there. So we've learned quite a lot and are working on slightly different premises than we were pre-COVID. So our proposed solution now is to work in partnership with People First Care, who provide a range of community facilities like residential beds and care outside hospital settings. So we are committed to purchasing NHS beds within the facility, but that it will be a joint model offering residential care, but also health beds if we need them and when we need them. It does align very much to work such as the Bluebell unit, to work in North Tyneside, where we're looking at joint home intermediate bed modelling, where we've got one team looking after those patients and only using those beds where necessary. So what we're trying to do is deliver partly the flexible bed model, but also achieving what is a gap, which is about residential care beds in that community. And really one of our challenges all the way along has been sustainability of this, and trying to do both of those hopefully achieves that. It is unique, and it's something that, you know, if it will be evaluating when, if it works well, it's a model that can be replicated. So just to go into a bit more detail, there'll be the residential care side of it, and that will be primarily for people who, as anywhere else, need a residential care bed, and so that will be in accordance with CQC registration. There will be people who develop needs as they go along, for which the community teams, particularly the district nurses, will help. We will be looking, as it is a partnership, at joint training opportunities, learning opportunities, working together. There are some building works that need to happen to just refurbish, upgrade those rooms so that they are appropriate for residential care. And you know, that will be led and organised by our partner organisation, and there's a few more details there. So as well as the residential bed side of it, looking to have a day centre too. The NHS bed model will be for probably three groups: the end of life care patients, people who are recuperating and slow stream rehabilitation, and those will be people who can't for one reason or another be managed at home. The clinical support for those groups of patients will be from community teams, and those community teams will be backed up by the Rothbury practice providing GP support for the NHS beds. We will have admission criteria. We will be looking towards that being a unified team that looks after people wherever they are, whether that's at home or in those beds, and it will be flexible, the exact number of beds. We know from our data that we don't need a huge amount, but it's variable at any one time what is needed. The key thing on this, it is a new model. We need to evaluate closely, and we'll want to do that very much in partnership with yourselves, to look at how those beds are being utilised, what's the reason for them, length of stay, how effective they are, you know, outcomes and so on. And I guess particularly, have we got the modelling right? Are there people who are unable to access those beds? What about patient satisfaction, staff satisfaction, and so on? So we need to look at all of that and make sure the model's working. I think what we hope will be some of the benefits are that since the beds in Rothbury were closed, that we are utilising a facility that's important, that's valued by the local community well. We know that there is a gap there for care home, for residential care beds, and we hope that that will be able to achieve it. We know that at any given time, there's a very small number of NHS beds that would be helpful for that population, so we're aiming to do that too. We hope that by having that joint model, it will provide you know, value for money and high quality provision there. There is the opportunity because there's a new employer there, and that brings with it jobs too. So there are some other benefits in addition to the actual direct patient care. So far we've established a Rothbury board and an operational group. We're obviously doing our presentations to yourselves. We've got a presentation to the OSCE on the 5th of April. There are building works, as I've mentioned. We've got quite a detailed communications plan, and we have that commitment. We're meeting regularly with local residents and stakeholders to keep updated with the plans, how they're progressing, when we're ready to go on that. That's all I'm going to say, and then we can open that up. I'll stop sharing slides. Thank you.
Thanks, Paul. Rachel, I think you're going to carry on now, is that right? And maybe make reference to the questions that were raised by the lay governors as well.
Yes, thank you.
Thanks.
So I just wanted to point out, obviously within your pack there is a quality and equality impact assessment, which is overall positive from a patient quality perspective. Although it hasn't started from a patient experience, Northumbria colleagues have worked really hard with the local community, and there has been some local comms already sent out, and people are fairly positive about this new model, which is great. And from an equality point of view, we're not expecting any negative impact. As we've already mentioned, this has been discussed by Clinical Management Board and it was approved by them, but there were some conditions in which they raised, some of which actually Paul has covered, and we have been working really closely regarding this. But just for members and just for clarity, this is around the overall cost of the model, and we don't want that to cost any more than what is already provided from a funding perspective. From a point of view of the NHS national contract, we want to make sure that there is a proper subcontracting arrangement in place with the care provider, People Care First, or People First Care, actually, isn't it? I do get that the wrong way around. Paul had mentioned wanting to do this in partnership, and we'd really like one of our clinical directors or clinical leads to be part of that evaluation programme. We do need that to be really strong so that we're really clear how it's worked, because we are aware that it's new, and we think that primary care perspective would be really important. And obviously once the evaluation is complete, it'd be really good to have that presented back to whatever ICS level committee place there is, so that we can see the outcome of that. And of course that engagement continues, which is absolutely critical, and I know that the campaign group and the local councillor have obviously been very involved, and we just need to maintain that with the local community, because it has come a long way. But I think overall from Clinical Management Board, very much recognised it is a good solution to provide some beds, some of which health, but also that wider need that people did talk about from a point of view of respite care would be provided by the social care model. So from that point of view, it does feel to be a really positive model. So I know that there was one question actually raised, and Karen actually had that. I don't know whether we just want to open the questions and just ask those questions by the people that had them. And I'll hand over to you, Graham, to field the questions. Karen, do you want to ask your question first? Or?
Yes, okay. I was just wondering, in past reports that we've had, it talked about that 12 beds wasn't a viable proposition for a care home because it just wasn't big enough to support a business. So what I'm wondering is, how is this model going to be feasible for People Care First to be able to actually sustain the service there?
Shall we go round all of the questions first and just see how to, and then we maybe answer them in one go, if that's okay? So Janet, would you like to ask your question, and then Siobhan?
Thanks very much, Graham. Yes, it's mainly based around evaluation. It's an interesting model, and as you say, Paul, it's a new model. And you did say at the beginning, it's possibly where we hope to go in the future. So I think evaluation is particularly important if we're looking for how we might proceed in the future. And will there be a way in the evaluation report to look at how or where patients admitted to the new Rothbury beds would be likely to have been treated previously, so that we can assess, is the model providing an additional service, a new service, or is it a continuing service in a more appropriate setting? because it'll just show us, is it expensive? Is it less expensive? Is it more successful? Is it less successful? I don't know how easy it would be to do that, but it might be useful. The other question that I was raising, but I think it's been answered, I just wanted to confirm that the respite care is not part of the NHS bed model. And I think from something that Rachel said, she's confirmed that. Thanks.
Okay, thanks, Janet. And then Siobhan.
Thank you, Chair. I'm Siobhan Brown, Chief Operating Officer at the CCG. My question relates to the Clinical Senate. So, Paul, you're describing a very innovative model, and I know the Clinical Senate have been involved with us in the past. Are they going to be part of the evaluation going forward, given that this might be models that we might want to look at for the future?
Okay, thank you. Paul, back to you, or Teresa and Marion as well. Was there anything else that you wanted to add to this?
Well, shall I pick up on the evaluation side of it first? Because I think those are all good points. If I've come to Janet's questions first, I think we're not expecting, and the numbers are likely to be small in terms of who's using those NHS beds. So I think what we need to do is look at those as individual cases almost and just try and unpick some of that. So there'll be some quantitative data that will be important around, how well are we using beds, how many people are needing to use them. But I think the more crucial bit, as you say, is what are we using them for? Is this a shift of, I think some of them we hope will be a shift from people who are currently in beds elsewhere to closer to home. I guess there's a few things going on, and we're managing more complex people in community settings through primary care and community care working together, and this is part of it. So I think we're going to have to do both quantitative but also case reviews to just understand exactly what's going on with that. Siobhan, I think your point about the Senate's a useful one, and I think to date we haven't involved them in this, and I think as Rachel said, we've started to have conversations about evaluating between the CCG and the Trust, but I think yes, I mean that probably would be helpful, and we can perhaps talk offline about how best to get them involved in that process. On the, I don't know if Marion or Terry, in relation to people care first.
Yeah. Just on the first question, we've been working with People First Care for quite a while now, and they've given us assurance about the ongoing commitment that they've got to Rothbury. So they've done their own analysis about the cost effectiveness of those beds. We've said 12. There is some possibility that that might increase to 15 over time, depending on the demand that comes. But they've given the Trust assurances that they think that the model that we've put in together in partnership is a viable model for the Rothbury.
Thank you. Okay. Fairly comprehensive piece of information we've had today. Lots and lots of work has gone into all of this. I'll pause for a second to see if anybody else wishes to raise any other questions at the minute. Okay, so I was going to come back to you, Rachel, I think, and just allow you to summarise where you think we have got to now. Maybe a word just to confirm from our perspective again what we feel the next steps would need to be. We've got a paper in front of us which we've provided comment on, and I'm minded to suggest that we should approve the model with the recommendations below. But Rachel, if you could just give us your thoughts on that, please.
Thanks, Graham. And I think it's also worth pointing out from a point of view of questions. I know that the public were able to ask questions today, but we didn't receive any questions from the public with regard to Rothbury, just so members were clear. I very much feel that this model is innovative. It provides a really good solution for the people of Rothbury, and we should go forward and approve it. I think members are raising issues around the evaluation because we are really keen to know how this is going to work, and I think maybe involving that clinical senate and certainly having that primary care representation on the board, and certainly the trust have put in place a structure to do that evaluation and have a really good engagement group with so it's well set up to deliver a good evaluation. I think we need that, don't we, so that we can be able to come back maybe in 6 months' time and actually say how it's actually working. So I think that's a key part of what we need to do next. The CCG are involved with those groups as well, so that's good. We're very much working in partnership with regard to that, and I think that should just continue as we go and learn together what opportunities this might have for future services. So I think, minded by the conditions that CMB put, I think I would be recommending that board would approve the model to go forward with those conditions, and that we inform the trust of that, and then work together to evaluate the model.
Thank you, Rachel. Does anybody have any final questions or points to raise? No, and I can see largely through this presentation, people have been nodding and smiling and are on board with this. Thank you. I can't see everybody. If I could just say, can we approve this paper then, as suggested, and we look forward to the developments that are going to occur off the back of it. Thank you very much, Paul, Marion and Teresa, for joining us today. Really helpful. I hope you have a good day.
Thanks, everyone. Thank you.
Thank you. Right. That brings us back to item 5, which is the Accountable and Chief Officer's report. So that would be Mark and Siobhan, please.
Thank you. I shall kick off and then Mark can join as well. So I want to share with you 5 kind of areas of work that the CCG is very involved with at the moment. We're obviously in that very last week of March now, so a lot of our work is about end of year, planning for next year with the overlay of the integrated care system and what that may hold for us in the future. So people very dedicated to that. A few other areas that are very specific. One is we've been asked to methodology test a special educational needs and disabilities model from the Ofsted and the Care Quality Commission. You may remember a year ago we had our revisit, which went really well, and they signed off our whole strategy and approach. This week, we're working really hard with Ofsted and CQC chief inspectors. It's going well. It's very centred around the voice of the child and the young person and the family. So it's a very different model. And we're just excited to be able to help inform that. So just to let you know, that's going on, and it's a whole system piece of work. From the news, you'll be very aware about Ukrainians moving all over Europe. We too will be ready to accept Ukrainians locally, and I think some have already started to arrive. So just to let you know that, led by the local authority but working with health, we're going to be doing everything in our power to make sure that we have the right services and support wrapped around for people when they do come. We're expecting some of those obviously to have very complex needs given what's going on. So just to assure a governing body that we're looking at that. Our Director of Public Health is here, and later on she may come to this in more detail, but on Friday we're holding an Inequality Summit at our Rivergreen offices, very much led by the leader of the council, working with the whole system and the public health team. So we're very excited about that, and that's very much about working to the future now and dealing to the inequalities and outcomes agenda. And my final point is very much around engagement with our patients and population and public. And one of the key themes at the moment is access to primary care. So I just wanted to let you all know that the piece of dedicated research that we've been doing, where we've been interviewing literally hundreds of people across Northumberland about what matters to them and what issues they have and what solutions they suggest, has just closed. Chair, I'm very aware that we had some questions from the public on this, and I wondered if you mind me going to Janet to ask those questions and also questions from herself. Thanks.
Thanks very much, Siobhan. Yes, there were a couple of questions which came in from members of the public around primary care engagement. It's not strictly speaking on the agenda, so we don't have people here who can answer for themselves on this issue, but I'm prepared to pick them up as chair of the Primary Care Commissioning Committee because they are items we've had some discussions about at that committee. The first one I'll read out, I've got it here. It says, what impact will the loss of the Ponteland and Hayden Bridge Allendale GP practices have on the West Northumberland primary care network? And colleagues will know that this is referring to the reconfiguration of PCNs in the area, because there will be a new Northumbria primary care PCN. So this, I can't, of course, speak for West Northumberland Primary Care Network, but what I can tell you is that when the reconfiguration was discussed at the Primary Care Commissioning Committee, we did discuss in detail not just the new proposal, but also the effects on those who would be left in the original PCN. And what came over very clearly at the meeting was that there had been significant discussions between both Northumbria Primary Care and the West PCN. They were both determined that they were going to work constructively together to make this work. And we, in fact, received very considerable assurance at the committee that they would be sharing ideas, they would be sharing new ways of working, they would be supporting each other. So although they will be two separate PCNs, they are, of course, geographically linked, and therefore they are determined also to be linked in terms of support and ways of working. So I can't tell you how it's going as of today, because, as I say, it's not on the agenda, they're not here, but certainly they were both very constructive, very positive, and it certainly gave the committee considerable assurance that they would find ways of working. And Northumbria Primary Care in particular were determined, as the ones who've initiated this change, were determined to ensure that individual practices weren't in any way disadvantaged. One thing I do want to mention, which I for the benefit of anybody who's listening who isn't a member of governing body, we have to remember that primary care networks are just the ways practices work together, effectively behind the scenes, you could almost say. They're not changes to services. And I think patients need to bear that in mind and therefore not be alarmed that these sorts of arrangements will affect the services they're getting. If there is any effect, it will be very much incidental to better management and better organisation and better working together behind the scenes. It's not a change to the way services are being delivered at the front end. So I hope that's some assurance to everybody on that one.
Thank you, Janet. Was there another question about engagement? I can see Ben has got his hand up. Ben, if that question is relevant to this, do you want to ask it now? And then we'll go on to the other part that Janet was asked about engagement, I think.
Yeah, thanks. I think it's an interesting point that's raised around the PCNs, and I just wonder whether in forming the NPC PCN, Northumbria Primary Care PCN, this new PCN, whether there is a plan to evaluate that and look for any, actively look for any unintended consequences that might have come in sort of following on from that question from the public there.
Do you want me to pick that up if I can, Graham?
If you can, I think probably there is an action point to take away to make sure we explore that as well, Janet, but if you'd like to respond now, that would be helpful.
In fact, that was what I was going to say, Graham. I'm not aware whether there is or isn't, so I think it should be picked up as an action point.
Okay.
I can't tell you on that one.
Thank you.
Okay, do you then want me to move on to the second question, which again, I've got it here, I'll read out. Would the lay chair, which is referring to Primary Care Commissioning Committee, so is me, would the lay chair please state whether she is happy with the public patient involvement in the organisation and management of general practice? This is an interesting one because it's a big question, because each practice or group of practices has its own way of working, of organising and managing patient and participation groups, and so practices will vary. And I can't, of course, say that I'm familiar with how every PPG works, or being involved with all of them. We used to have a lot more, or I used to have a lot more individual contact with the PPGs before COVID, when we had public meetings and representatives came along and we had the opportunity to talk together. Of course, we've lost that over the last 2 years or so. But certainly, generally speaking, my impression meeting these people and working through various changes that have happened, that have come through the Primary Care Commissioning Committee, my impression is that generally speaking, practices do manage well with their PPGs, and PPGs feel that they have a good input into the practices. But I think we can always learn. There are always ways of improving. There are ways of learning from other people, new ideas. And I do think this will be particularly the case over the last 2 years. I don't think it will have been as easy for PPGs over the last 2 years. And I can imagine that there could be areas where patients feel it's been very difficult to be sure their voice is being heard with everything that's been going on and the difficulties that they've been facing over the last couple of years. So although my personal experience dealing through the committee has been good, I would not be surprised if there are felt to be challenges out there arising, particularly over the last couple of years. And I'm sure the CCG is very willing, well, I know through Pamela and her staff, the CCG is very willing to do what they can to try and work with groups and, if necessary, refresh ways of working following on from the last 2 difficult years.
Thank you, Janet. I'm going to hand back to Siobhan because we were dealing with this in part of her report. If anybody did have any other questions to raise on what Janet has just said, raise your hand, but otherwise we'll go to Siobhan, and she was going to pass to Mark, I think.
Yeah, thank you. Yes, I was. I had finished my part, and I'll just bring Mark in now for any other further updates.
Thank you, Siobhan. Thank you, Graham. Just a quick couple of bits on ICS-ICB, if I can. Firstly, everybody will now be aware that we have people in place for the vast majority of the posts for the executive directors of the ICB. And congratulations to John Connolly for getting the finance director's post. Work continues. I think we're all aware work continues behind the scenes on looking at the detail of the operating framework for the ICB. And through various fora, we've been asked to look at that and offer responses back. We are still then working on key elements that will then provide us with a further set of detail. So that's further detail on the operating framework, further detail on the structure of the ICB, given that we now have the structure and we now have incumbents in place for the board. Also schemes of delegation. And I think that will be helpful when we get to that place. It will also be extremely helpful for us because it will then help us inform those discussions at place to understand how we would like to respond to that in terms of picking up those delegations of duty. In terms of timescales, we're still working to the target date of the 1st of July, and that hasn't changed. Work continues in our CCG as it does across all of the other CCGs in terms of due diligence in order to be in the right place, in order to be able to innovate our assets, liabilities and responsibilities to that new organisation when we get to that point for the 1st of July. So I'll stop there, Graham, but I'm very happy to answer questions if anybody has any.
Thanks, Mark. It's worth mentioning that ICS update is part of our private meeting agenda in the second part of the morning. So if there's specific things around process that you'd like to understand, we can discuss those there. But from assurance point of view in the process that's going on, if there's anything you'd like to ask Mark now, please raise it. Okay. Thank you very much, Mark and Siobhan. We shall move on then. So item 6 on the agenda, 16 in the agenda pack is John Connolly and a finance update. Over to you, John.
Thank you. Sorry, just put my camera on. Thank you. I I don't know if there's too much to say about the finance report this month. We did go through it at the Corporate Finance Committee, as we usually do. This is month 11, and obviously we're very close now to the year end. As Siobhan said, we've only got a week to go. In terms of the report itself, there is a recap on the arrangements under which we're operating. Those haven't changed, and really the position in terms of current performance and forecast to the year end hasn't changed in this report, and it has moved forward a little bit in the way that we would expect. So all the kind of explanations and narratives in there are pretty much unchanged. We have a forecast year-end position which is around that 4 million surplus. That might reduce a little bit as we get towards the year end, because we may be able to move some of the ageing well funding into our providers. That's up to 1.6 million, but I think there are also potentially benefits or lower costs that might cover some of that going the other way. So anything that we can move would hopefully support an increase in next year's flexibilities. So overall, I think not too much has changed in this position, and there's very little risk around delivering certainly our plan, and probably a significant improvement on that plan or surplus over the original plan. But obviously happy to take any questions. Thank you.
Thank you. Any questions on any of that? As John said, we went through it in some detail at the CFC meeting last week. Yes, Marius.
Thank you.
Could you introduce yourself, Marius, as well,
I
please?
am Marius Adamo, secondary care doctor for the CCG. Is a future focused question rather than a current one. I see there has been quite a bit of stability in the budget with the block contract arrangements, and wonder if they'll be carried forward in the new financial year, or how much in, so the system can stabilize and benefit from it before the incentives come, rather than go to an activity-based system.
So the arrangements for next year are similar in some respects, because the majority of the funding for elective and non-elective activity is on a block basis, but they aren't centrally calculated blocks. They are more locally calculated blocks, but with some principles for calculating those, and we've used those principles. And then in a similar way to this year, but not quite the same, there is then the elective recovery funding, additional activity, which is distributed on the basis of additional activity from a baseline. So I think what we can look forward to, certainly for as it looks now, is a blended approach, really, on the elective side, which will be a baseline of block funding, which is then adjusted dependent on levels of activity. So it's a bit of a mix, really, Marius. I think there is a bit of a trend a little bit back towards activity-based payments, but there is still that core block there.
Okay, thank you. Any more questions on any of that? No. So on behalf of the governing body, thank you, John. We accept your update. We've given comment, and we realise that the situation going forward is unpredictable at times, and we've considered all those factors. Thank you.
Thank you.
And congratulations as well.
Thank you.
From all on the governing body too.
Thank you.
Okay. So now we're going to item 7 on the agenda, 41 in the agenda pack, Clinical Management Board update. And in Dr. Robin Hudson's absence, we're going to go to Dr. John Warrington, who actually did chair the CMB on the last occasion as well. So over to you, John.
Thanks, Graham. I'm John Warrington. I'm one of 2 medical directors here at the CCG, and I'm a local GP as well. The report details Clinical Management Board's Performance and Quality Exception Report and also the Board Highlight Report from our February and March meetings. Firstly, the performance and quality headlines. Timeliness of access is the most common theme across the health economy, combined with pressures on a wide range of waiting lists. In the past, providers have responded to this by putting on additional waiting list initiatives, by recruiting locums or agency staff or outsourcing to the independent sector. But of late, due to staff shortages or even staff reluctance to take on additional work due to all the ongoing pressures within the system, using those alternative options hasn't really produced the additional required capacity to address the increased demand. Within urgent care, ambulance response time performance within Northumberland continues to remain significantly below the national standards, but encouragingly during January, there's been an improvement seen both here at Place and across the region compared to previous months. And there's good news in that there's been some continuous improvement against a range of NHS 111 metrics because of the impact of further investment that we've made in staffing, and that will, we'll continue to see that during 2022 as well. The performance of local acute trusts against the 4-hour A&E threshold continues to be below the national standard, which is an issue nationally, of course, as well. The number of people waiting for 52 or 104 weeks remains a concern, but local providers' improvement plans are beginning to show performance improvements here, which is good. And performance against the range of cancer indicators continues to be volatile, with Northumberland's actually underperforming against some of these thresholds, but work is ongoing to address this important area. Relating to dementia diagnosis rates, that was covered in Robin Hudson's action point at the beginning of this meeting. Worth mentioning that all local provider organisations are exceeding the national England average for absence rate of 4%. We've included a summary of serious incidents, along with the findings and actions from the root cause analyses undertaken by our providers with those, and they're in the report. Secondly, in terms of the highlight report, CMB received a presentation regarding the new model of care for Rothbury Hospital, and members scrutinised those plans ahead of today's governing body meeting. CMB received a report on a proposal to jointly commission a specialist dementia facility in Northumberland with the local authority. This would provide a local service aiming to improve the quality of care afforded to people with very challenging behaviours, and specialists in the mental health provider CNTW agree that this would be a very positive addition to the provision of care home placements in Northumberland. CMB also considered a report on the provision of nursing care placements. Since February 2020, there's been a reduction in nursing home placements, which is likely all to be related to COVID. And this has resulted in a loss of income that's disproportionately affected certain nursing homes. So whilst we wait for demand for nursing home places to recover, CMB considered a range of options to essentially alleviate those difficulties and mitigate them. CMB also considered a report about Tier 3 weight management services at Northumbria Trust, which is also known as Food for Thought. During the pandemic, and due to the need to prioritise NHS resources, a significant gap in service has developed, and there's now a waiting list of 300 patients as a result of that. So additional funding and capacity has been agreed by CMB that will address this backlog whilst making sure that the service also meets NICE guidance criteria. Separate to the CMB report, we want to acknowledge that governing body has received questions from the public relating to issues including concerns around timeliness of prescription ordering process in primary care, and also concerns around timeliness of consultant letters to GPs and the results and recommendations they contain being acted upon and communicated to patients in a timely and efficient way. The CCG is committed to continuously improving all areas of performance and quality in primary care and also across the system, and all of the above will be picked up by the CCG team, and answers will be communicated back to each person who asked the questions. I'll hand back to you now, Graham.
Thank you, John. Questions, please. So Siobhan first.
Thank you very much. Thanks, John, for a really strong summary. I do want to highlight the ambulance service and 111. As a board, we've been championing these services and trying to get improvements in these for years and years. We are starting to see that change. It is volatile, but to achieve 3 out of the ambulance response targets and to see that 111 abandonment rate go down and call answering times really improve, I do think it's a testament to joint working, and both from the ambulance service and our commissioners as a bigger team, and also the funding and resources that we're putting in. So I hope that that's the start of a new time for us in terms of becoming the best performing ambulance service in the country. I just wanted to share that. Thank you.
Okay, thank you. And then I can see Janet and Karen and Steve all with hands up.
Thanks, Graham. I feel a bit churlish now that you said that, Siobhan, coming in with my question about ambulances. I note the improved position. Obviously, the 111 news is good news. Thank you. I note the improved position in December for ambulances, John, but also activity decreased. Do you think it's a real improvement, or is it just there was less activity? Is my first question. I then have a second one.
Why don't we get all questions out and we'll go around all the lay members' questions, and then we'll come back to John.
Yeah, and the second question also related to ambulance performance, and perhaps Siobhan sort of answered this. We have been looking at these key actions, the recent ones for months, previous actions for years. And my question is a very broad one. Do we have evidence that some improvement that we see is actually directly attributable to those key actions, or is it just volatility? Because in the past, we've always claimed these improvements as improvements, and then it's always turned out to be volatility. So I'm just wondering, is there any evidence, or do we still not know? Thanks. Okay,
thank you. Karen?
My question was about the serious mental health illness health checks. It says on page 67 of the document that we're likely to not achieve the target for this. So my question is really, how does that impact on our patients if they don't get their health checks? Is it an issue for them and their health? And secondly, does it have any effect on the CCG in terms of lack of funding for achieving the targets?
I think they're good questions. I'll come back to them when we've heard Steve's questions.
Yeah, hi, I'm Steve Brazier. I'm the lay member and audit chair. My question was really around the learning experience from the call abandonment measure, which is thankfully improved significantly. But in absolute numbers, there were a lot of calls that were abandoned. And it's probably just a coincidence, but the sort of peak of that was in October, and the performance of A&E also troughed in October. And I just think we talk a lot about the cause and effect between 111 and attendances at A&E, and it's not very often we actually get a sort of live bank of data, which is probably quite rich, that we can sort of investigate and look into to see, you know, whether that how significant the cause and effect is. So it's just not losing that one, John.
Okay, thank you. I think those questions on ambulance and response and is this volatility or related to our improvements, really complex questions to answer. I'm seeing Siobhan nodding. I was going to suggest that we take that back to the team, but think about that in why and try not to answer it all here. But I don't know if there's a specific comment you'd like to make just now, Siobhan.
We will take those back, and we will look at some of those cause and effect. I think part of it is time will tell in terms of the volatility, but we do know some signals have changed. So, for example, handover to clear has gone under 14 minutes now, which is brilliant. But it's so multifactorial. But we're happy to go away and take a bit more of a look at it. And I don't know, John, whether you've got a clinical view on that.
No, I think that all sounds fair enough. It needs more detailed analysis, really. And I think the point made about volatility versus actual improvements is, we take that very well and understand that. Thanks.
And carrying on into Steve's points about abandonments and the impacts of that, we'll pick that up in the same group because that falls there. The SMI side of things, John, I was just going to ask you to comment on how do you think we should take that question forward?
No, it's a valid point, isn't it? It's it's a very important area. SMI checks are important for this group of patients. We know that CNTW have actually got teams of people working to complement what primary care is doing on this as well. So case finding and supporting individuals and all working together across agencies, providers. The real answer probably comes down to pressure though within the system, particularly in primary care, which has never been busier and needs to prioritise, urgent emergency work, long-term conditions planning, and the whole gamut of it. But the CCG is actively supporting primary care to deliver on all that, incentivising and supporting, and it's just another area that we need to keep a close eye on and make sure we improve at.
We can take that question back. Dr. Kathy Peterson is very closely involved in the SMI check. So I think what we'll also do, Karen, is just raise that as a point to her and ask her to provide some feedback to you before the next meeting, if that's okay. Thank you. Does anybody have any other questions on this item? No? So thank you very much, John. Thank you for the report. We accept that and valid comments made. So now we are moving to, we've done item 8, so now we move into item 9, the strategic and operational risk registers, page 95 in the agenda pack, and I think Richard is going to take us through this.
I am indeed. Thanks, Graham. Hi, everybody. I'm Richard Hay, Head of Planning and Operations at the CCG, and here to present the strategic and operational risk registers and their current position. This is something we've discussed a number of times before as a governing body and as a clinical management board, and is the first time, I guess, in public we've given an airing of our revised and refreshed risk management arrangements, and it references in the paper the fact that this is a culmination of 12 months of work to that end to get us to a point where we've got a refreshed and revised strategic risk register that gives hopefully a much better and more comprehensive position of the major risks to the CCG and the achievement of its strategic objectives. I don't intend to go through the paper in detail because you've all had the opportunity to look at it beforehand, but just to summarise, as I say, there was a tendency previously for our risk registers to have become slightly overcomplicated, and key risks having been duplicated and diluted across multiple entries. So there was a need to re-look at that and pull everything back in really and make it as concise and comprehensive a document as we can. This was approved by a private meeting of the governing body in January, and has also been to the clinical management board, and we're now in a position, as I say, to share it publicly. To give an idea of the scale of the work that we've undertaken, we've looked at the risk register in its previous state and reduced it from 29 risks down to 13, and I think that's a distillation rather than having discarded risks. We've distilled key risks that were diluted across multiple entries into really comprehensive risks, and that's what we present before you today. So just to summarise the current position we find ourselves in terms of red risks that we have strategically, and this is Appendix 1 to your paper. The risk around system resilience remains our highest risk in terms of the score, particularly because of the ongoing COVID situation and the work that we're undertaking to address the significant backlog in elective appointments and things for patients. So that's something that remains very high on our agenda. You can also see from the remainder of the risk register there the mitigations that we have in place for that risk and lots of others which have reduced the initial risk scores down to a more manageable level. And happy to take questions on any of the risks that we've got on there. In terms of our operational risks, this is the next phase of that project, I guess, to refresh and revise our risk management arrangements. Having looked at the strategic risk register, we're now turning our eyes to the operational risk register. At the minute, our risk tolerance level is set at 12, so any operational risks which score 12 or above are escalated as a matter of course to the Clinical Management Board and governing body for their attention and oversight. They're the ones that are presented in Appendix 2 to your papers. And yeah, again, to summarise, I think as we've discussed previously on the Clinical Management Board item there, access to treatment, diagnosis and the performance continue to be the things that occupy our mind most prominently in terms of risk management. The task going forward in future meetings will be to bring a revised and refreshed version of this operational risk register as well, and hopefully focus ourselves in on those operational issues that are really most pertinent to our achievement of our objectives. We're doing that using a new system as well, where we're innovating as much as we can and working to integrate our risk management arrangements into our programme management office that we have at the CCG. So bringing the operational delivery of projects and our delivery plan in line with our risk management, so that we can reference key projects as mitigations to risks. Essentially, what our risks are telling us are the key things we need to pay attention to and focus on as an organisation, and we can clearly evidence by integrating those two systems those projects which are actively targeting the risks that we've got and mitigating their impact. So as I say, I don't intend to go through the risks line by line in particular detail, but more than happy to take questions from members on any of the content of the risk registers or things we'll be doing going forward.
Okay, thank you, Richard. I can see we've got some hands up. I was really going to comment on this in that to a member of the public, seeing a chart like this would be incredibly confusing, I would suspect. However, it is an incredibly important part of governing body business, being able to identify what's going on within the organisation and see that we are performing as we should, and identifying areas and identify the mitigating factors. And without clear risk registers, it would be extremely difficult to do the job correctly. So thank you very much for that, Richard. Karen and then Siobhan.
Thanks, Richard. I think it's really much more comprehensive now and much clearer and easier to manage, I think, having the smaller number of risks. Just a question about the consequence descriptors. Obviously, now we've got much more detailed consequence descriptors than we had previously. But in some of the risks that we've got, as a result of the mitigations we put in place, it seems as though the consequences of that risk happening reduce. I just wondered if you could give me a bit of assurance as to how that comes about, how you're able to reduce the consequences of something happening as a result of the mitigations we put in place.
Yeah, I'm happy to pick that up, Karen. I think it's a really interesting point, and absolutely mitigations that are put in place can reduce both the likelihood and consequence of a risk occurring. So if we use COVID as an example, the vaccination as a mitigation to that both decreases the likelihood of big impacts in terms of illness and serious illness and mortality, but also reduces the consequence for a lot of patients and to the organisation as a result. So there's no kind of hard and fast rule in terms of whether you can only adjust likelihood or only adjust consequence. And when we're scoring and analysing our risks, we take kind of everything into consideration collectively. But we do go through a process of assurance as a programme management office to make sure that we're doing that consistently across the board. So yeah, likelihood and consequence scores are regularly reviewed, but can move both up and down.
Thanks, Richard.
Thank you. Siobhan and then Marius after that.
Thank you. Richard and Paul, I'm very aware of all of the work of the team on risk and the really innovative tools that you're using now. My plea would be, as we move into an integrated care system world, that we take innovations with us and that we learn and grow and develop. I think it's really, really important, and certainly for this board, I think to be cited on that as we move into the future really matters. And just to say thank you for all the work on this.
Thanks, Siobhan. Yeah, it's really exciting what we're doing. If risk can ever be classed as exciting in Northumberland, looking to try and integrate risk with our project delivery, and it really gives us an extra level of insight and assurance as a board into the the work that we're doing really is the right things to address the problems that we face. So yeah, it's something we're definitely keen to take forward into the new organisation.
Thank you. Marius, your light's gone out, but I don't know if that means that you've still got a question or not.
Still there, yes. It's just to express personal thanks to Richard about this work that has been going for quite some time, and it's been done in a methodical and professional way, and I wanted that communicated on our behalf.
Thank you. Yeah.
Thanks, Marius. If I can also just name check Rachel Long, in particular in our team, who's worked very closely with Paul and I on this piece of work and helped to take it forward. It's been a real team effort, but thank you very much for your thoughts, Marius.
Okay, Janet, and I can see Steve's got his hand up as well after that.
Thanks very much, Graham. I also wanted to say thank you to Richard and his team for the work they've done, but I also just wanted to remind governing body, when we talk about the difficulties of risk registers and the public looking at this, this is probably one of the most important single documents that any board ever looks at, because in a sentence, and some of you have heard me say this before, what is the work of a board? It is managing risk. That's what the board is there for. The executives do the hard work. The board manages the risk. So this is the single most important document we see, and the clearer it is, the better. It's also very much a forward-looking document. It's not saying to us, where were we last month? We all know where we were last month. It's saying, where do we fear we might be, hope we might be, 3 months, 6 months, 12 months. It's horizon scanning. It's what keeps us on track and what helps us to cope with things to come in the future. So it's an incredibly important document. And gosh, how can you say, Richard, can it be exciting? Is there anything more exciting than risk? So thank you very much indeed. I think it's a really good piece of work. And just one final plea to Mark, please. Mark, as we go from CCGs up into the new world, please, please, will you try and put in a word for decent risk management, because it's something that concerns me as I'm looking to the future. I'm not seeing much about risk management, and if anything, the new systems are going to be even more risky, and risk is going to be more difficult to manage, and how you work it through at different levels. So please don't let the future just pluck some ready-made system off a shelf which may not be fit for purpose in terms of risk management. End of lecture. Thank you.
Thank you, Janet. And Steve.
Yeah, it's just to echo everybody else, Graham, but probably from a slightly different perspective, that Marius, I think, came in with a fresh pair of eyes 18 or so months ago and looked at this and said, well, I'm not so sure about whether this is clear and understandable. And the big thing for me is, whatever the rights and wrongs of that is, the last 18 months, everybody's thought a lot more about risk and looked at risk more than certainly I've been used to at the CCG. So as audit chair, I really welcome that. A very minor sort of question for yourself, Richard, which is around, I always think there's safety in numbers by benchmarking and doing things like that. So it's just keeping your eye on the ball on what is on the other CCG's risk registers, because invariably we have a lot of the same issues and all the same things. And I don't think there's any harm in terms of staying close to, the people that in NEX about what everybody else has. It's just, hopefully we're doing that to make sure that, nothing's missed in this, which I'm sure it won't be, but it's always good to evidence that we've done that.
Okay.
Absolutely, Steve. Just by way of assurance, quickly, that is a piece of work we do at the minute and continue to do, especially with an eye on the new organisation on the horizon. So we meet regularly as governance leads and look at risk management in particular. And there's a piece of work ongoing at the minute about how we do risk management in the ICB and how we take our risks forward. Because, as you say, at the minute we do have 8 different versions of what is a very similar risk register that needs to be consolidated and address the challenges across the ICB without losing that focus on place. So that's something we'll continue to do going forward and report back to this board and the designated ICB board when it gets itself up and running.
Okay, thank you. I think that's all the questions that we had. Today we've talked quite generically about the risk registers and seeking assurance on them. We haven't delved into any individual risks, which sometimes occurs. We didn't receive any questions beforehand from any of the members about specific risks. So I will take it that you have reviewed the registers and that if you do have any other questions about any of the risks detailed there, you will contact us and let us know. But thank you very much for your hard work on that, Richard, and Paul in the background there, and Rachel. Thank you. Okay. Finished on that item. So that brings us to item 10, which is over to Liz Morgan for a public health update. Over to you, Liz.
Thank you and good morning, everybody. I'm Liz Morgan. I'm the Director of Public Health in Northumberland County Council, and I'm also Interim Executive Director for Community Services, which includes housing and public protection. So just 3 things I'm going to run through today. Obviously, a bit of a COVID update to talk about what we're doing as a local authority around Ukrainian refugees, and also to talk a little bit about the Inequality Summit that Siobhan referred to earlier. So from a COVID perspective then, cases are sort of generally increasing globally, and that's largely due to this BA2 subvariant, which is between 25 and 30% more transmissible than Omicron. There is some evidence that it might be levelling off in some countries, including Denmark and potentially Scotland. The ONS study is our sort of best reference point in terms of the prevalence of infection. It is a bit there's a bit of a lag, but in the week up to the 12th of March, that study was suggesting that the prevalence of infection has gone up again. So it went up from 1 in 25, I think, to 1 in 20. And in Northumberland, the estimate is that 1 in 30 people had infection at any one time during that week. It's increasing in all age groups, highest in under 11s, lowest in secondary school children, and in Northumberland about 20% of our PCR tests are coming back as positive, which is quite high. We're also seeing increases in admissions, and I think the latest data that I saw for the North East and Yorkshire suggested that about 48% of admissions of people who had COVID were admitted. They were admitted because of COVID rather than it being coincidental. And obviously we'll all appreciate that it doesn't really take much to disrupt service delivery, although I think actually Northumbria and CNTW have managed pretty well. So I think, I mean, obviously Ukraine has been dominating the news, and that's, you know, that's absolutely right. But I think what that has done is has diverted people's attention from the pandemic, and we are still very much in the middle of a pandemic. You know, the bottom line is that places where people congregate and mix are still hotbeds for transmission. So we really need to focus on using every communication channel to focus minds on what people can do to sort of manage and minimise the risk. We are expecting some further guidance on living with COVID this week. We're expecting it on the 24th. We were hoping to have the guidance around testing in care homes in particular earlier, but that hasn't come out with. And we're also expecting further guidance around workplaces and public and guidance for the public. But as you will appreciate, we are very much shifting towards managing COVID like we do other respiratory infections, and taking a more sort of generic approach. So we'll obviously see what that guidance looks like. But I think locally we're still very much managing the pandemic through the Health Protection Board, which still continues to function very effectively. So that's pretty much where we are from a COVID perspective. Siobhan talked about Ukraine earlier, and as a local authority, we are spending a lot of time and effort on looking at what we need to put in place to support Ukrainian refugees should they arise. So lots of guidance which is emerging from the centre. We're looking at how we're going to conduct housing checks, DBS checks, administer the financial support, and that guidance is continuing to emerge. And I think the question I wanted to ask the board actually was around the sort of advice that clinicians are getting in primary care about what the health needs, generic health needs of this population might be, because we can probably provide you with some links to some good websites which can give you that insight. And then finally, the Inequality Summit, which is on Friday. It isn't a conference, it is very much a working meeting. We've got two excellent speakers supporting us through the process. So we've got Cormac Russell, who's an international leader on asset-based community development, and we've got Professor Chris Bentley, who is a leading light on developing evidence-based frameworks to address inequalities. We've got a wide range of attendees coming from the public and private sector organisations, including housing providers and businesses. The event, we had to limit numbers, firstly because we wanted it to be a working meeting and we wanted the numbers limited to make that manageable, but also because of the COVID element, clearly we didn't want to squash too many people into a room. But actually the event has been hugely oversubscribed, which I think demonstrates our sort of collective appetite to try and address this particular issue. I think, the challenge for us is going to be how we implement changes which are going to be enduring and which survive political, fiscal and organisational planning cycles. So, but anyway, it is very exciting. I'm really looking forward to Friday. And that's about it from me. Very happy to take any questions. Should anybody have any? Deathly silence.
I'm not silent. Thank you very much. I have unmuted myself correctly this time. Okay, so thanks for that, Liz. Lots of things there. There's a theme emerging, which I'll come back to when I do the key points around what we've talked about today. Does anybody have any questions? Certainly, I'm just going to comment this morning in our informal directors meetup. There was quite a bit of anxiety raised about the changes that we're going to experience with the lack of testing. And certainly we would be looking for some strong working between us and you to make sure that primary care knows how to inform our patients about what's happening and how to deal with things effectively there, because there is a shift in what's happening. And I think we're left with a little bit of uncertainty just now about what that means for everybody. Okay, so that's woken up some people. I'm going to come to Paula and then I'm going to come to Janet.
Thanks, Graham. I'm Dr. Paula Batsford. I'm the long-term conditions lead for the CCG. It was really going back to the Ukrainian refugees that we may be hosting in our area, and what Liz alluded to about having sort of a pack for primary care, and I think that's going to be really important. I know with the Syrian refugees that we've been hosting, that there have been challenges, particularly around translation translator availability and things like that. So I think that's going to be really important that we've got all those ducks lined up, because obviously these people have gone through an awful situation, and then to find yourself somewhere where you're anticipating that things will be happening, and then to find there's blockages which we aren't able to unblock potentially easily at that moment in time. So having all those ducks lined up, I think, is going to be really important, just to make the transition for them as smooth as possible, and to make us feel like we're being able to provide them the services that they require as well.
Thank you. Thanks, Paula. Yeah, very important. And Janet.
Thanks, Graham. Very obvious point. Will we get some sort of summary of the Inequality Summit after it's happened? Because it sounds really interesting. Perhaps something that the governing body might actually like to know about.
So what we're not going to get out of the summit is an inequalities action plan. But what we will get out of the summit is the foundations on which we can build an inequalities action plan. And the intention is that following this event, we'll have 5 more local conversations to build on the sort of rich conversations that we're going to have on Friday. And those will help us to develop an action plan for Northumberland as a county. And it does, the action plan does have to cover all the bases. So it does have to cover the wider determinants of health, how we deliver services, how we work better with communities. That's the crux of how we need to work going forward. But yeah, of course, I mean, the CCG is going to be absolutely critical to success. So yes, we need to make sure you're informed.
Thanks very much. Even if it's just something informal on the private agenda to be going on with, that would be great. Thanks.
Yeah.
Thank you. I'm mindful of the time, so I've got Annie and then Ben, and then I'll draw this element to a close, if that's okay.
My question is about the Inequality Summit, and not repeating what Janet's already covered. My thought is the COVID actually brought the service, and now inequality is a threat through a lot of that we do. So definitely very welcome the output of Summit that allowed us to probably have a more coherent framework to put together a lot of inequality work in different arenas, actually. So really exciting and looking to hear more.
Okay, thanks, Annie. It wasn't quite clear how that came across, but I think you've voiced a great interest in what's going on and the importance of it, and looking forward to the outcomes. Okay, thank you. And Ben.
Yeah, I just want to reflect what you said, Graham, about the COVID testing situation, and just encourage some really strong comms from the CCG about this. What you used the phrase treating it like any other respiratory illness. I think that was the phrase, and I think that phrase, first time I've kind of heard that actually, and I think we need to try and really work together to try and work out how we're going to communicate that message, because I think everyone's, certainly in healthcare workers, still treat it like they've got to test and isolate themselves from their colleagues, and then we've got patients as well and their expectations.
Okay. Go on, Liz. Thank you. If you come back on that, and then we'll
yeah, I mean, I think it is, it is going to be a gradual shift, and we really need to see what comes out of this latest guidance, particularly around testing, because I do have some concern. Well, I do have a number of concerns about some of the things that are being proposed, and of course the other issue for us is around surveillance, because actually we need a level of testing to provide us with information about what is going on where, because although the ONS survey is, it's great and it's fantastic that funding is going to continue, it is probably 2 weeks behind what's going on at the moment. So, a certain level of testing is going to be really important, I think.
Okay. Thank you very much. Thank you all for your questions there. So we'll watch that space with interest. So moving on, locality meeting and assurance key points. I think the main point today is the approval of the Rothbury Community Hospital proposal to take forward. And there were other themes. The Chief Officer's report, I think, goes in its entirety to localities anyway. But within that, the positive news about being closely involved in Ascend inspection and the process that we've made over recent years. The idea of Ukrainian refugees coming to Northumberland, we cannot afford not to have been prepared for that to happen when it occurs. And the Inequality Summit, which is a really positive thing where all agencies are working together in Northumberland for that. Paula?
It was just, is it just a point of clarity? I think the locality meetings are being replaced by the members meeting, if I'm correct. So it would be that these points may be being raised at the members meeting in general rather than at individual localities for April.
Okay, perhaps what we should do is make sure that the locality directors circulate them to their practices with any comments and ask for feedback from localities, and we'll also reference them at the members meeting there. Thank you. Governing body forward plan. So looking at that, we've got the usual standing items, but for the May, the one that stands out to me is primary care capacity and demand. And I'm hopeful that we'll have the feedback from the engagement that's been going on and the activities to engage with the patients about that. Paul, your name is against that one, but I'm conscious that will be largely from the primary care team, I would expect.
Yeah, absolutely, Graham. We'll get Pamela to do that.
Perfect. Thank you very much. Does anybody have any comment on the forward plan? Okay. Item 13, information. So standard public minutes for acceptance and for information. Does anybody wish to make any comment about that? All those minutes are there for information. Siobhan?
Just one, Graham. I think we wanted to reference the sign-off of the value-based commissioning policy at the CCG forum. Really important piece of work that John's particularly involved in, and just for noting.
Thank you very much. Yes. So, John, thanks for all your work that goes into that. I can't remember Matthew's surname from South Tyneside who presented to the joint committee, but they were accepted at the joint committee.
His name is Matthew Walmsley.
Thank you.
Yeah.
Okay. Any other comment on any of that part of the agenda? No. We have had no other business submitted prior to the meeting. Does anybody wish to raise anything? And the date and time of the next governing body meeting is the 25th of May. So I'll bring the public meeting to a close. Members can just hang on for a second afterwards and we'll agree what time to start the private meeting.